Hi everyone. We're just going to wait for a few minutes before we start. Okay. We're still a bit more people joining us. Just we'll wait 1 more minute and then we'll start. Okay. One raise hand. Okay, good morning, good afternoon, or good evening to everyone, wherever you may be joining us from. My name is Anne-Claire Stona. I'm the Global Mental Health Program Lead at the SingHealth Duke-NUS Global Health Institute, sorry. And our programs aims to raise awareness about mental health in Asia, but also to strengthen the mental health ecosystem in the region through research, capacity building, and network development. And in particular, we host the Asia Hub of the Mental Health Innovation Network. So I'm very delighted to welcome you all today for this special event, which marks the launch of our report on children mental health and well-being in Singapore, looking at interventions focusing on prevention, promotion, and literacy. But this event is not only the opportunity to share about the findings of our report, but also to explore, the broader landscape of children mental health intervention in Singapore and beyond in the region, and to highlight global initiatives and ongoing discussion in this field. So for today's event, so it's an online event, and we have about 270 registration. So we're very, very happy with that. And hopefully those who won't be able to join us will be still able to watch the recording after, that will be published on both our Global Health Institute website and the Mental Health Innovation Network website. So we have enabled the chat platform, so feel free to use it to introduce yourself, share about where you're working, where you're based. We love to know a bit more about the participants of this webinar. So this webinar will run for about 90 minutes. We will begin with the presentation of our mapping, so for about 20 minutes. And then this will be followed by a moderated conversation with our panelists. So we're very grateful to have 3 panelists with us today from Children's Society in Singapore, from UNICEF, and from Orygen Global, and I will introduce them later. If you have any question during the presentation, during the discussion, please note that or type them in the chat. And we'll have we're going to open the discussion to the audience at the end of the webinar. So I will I'm very pleased to first start by sharing our report. I will share my screen and we'll begin. So I hope everybody can see the screen. So please note that this presentation is really a snapshot of our full report. You will find way more information in the report that is available on our website, and we're going to share the link with you all like in a minute in the chat. So it's really a snapshot to just understand like what some of the key findings of our project. I want to start this presentation first by acknowledging, all my team's like contributions. So thank you very much for leading and conducting this project with me. Thank you to all the many professionals and individuals who contributed to this like work, to this project, to the survey, to the interview, who participated in our workshop. No, thanks to you, we've been able to produce this report. So I'm very grateful for that. And I also would like to extend my deep gratitude to Octava Foundation for their support. So this mapping focuses on children aged 3 to 11 in Singapore, and the interventions that support them in the area of mental health well-being, mental health promotion, prevention, and mental health literacy. And I think we're all aware here that the children's mental health and well-being is very crucial, with long-term impact, extending way beyond the adolescent period. So this mapping draws upon the Singapore National Mental Health and Wellbeing Strategy that was published in 2023 by the Singaporean government, and which adopts a tier-cared framework and emphasizes a lot on mental health promotion, prevention, and also youth mental health. With a lot of initiative for young people, especially like since the COVID-19 like pandemic. But traditionally, when we talk about like youth mental health, the initiatives and activities, focus a bit more, center a bit more around like adolescent mental health and young adult mental health, leaving a gap for the younger age. So this project and this mapping really focused on the younger age, like the preschool children and the primary school like students, to understand like in Singapore, like what were the intervention like implemented for this age, who are the key stakeholders, what are they doing, how they are supported. That was really the objective of this project, to map existing mental health and well-being intervention for children aged 3 to 11 in Singapore, with a focus on promotion, prevention, and literacy. We wanted to also assess the reach and the consistency of this intervention and programs to identify like gaps and opportunities for improvement. And we hope that these findings will inform the funding agenda and future research, but also like policy and program development in Singapore and maybe in the region as well. You'll find more details about our methodology in the report, so I won't spend too much time, but we adopted a mixed method approach where we disseminated a survey with about like 40 questions. We also run interviews with program implementers from public, private, and civil society organizations. And we run a stakeholder validation workshops where we presented our findings to all the participants of our project, with the aim of like confirming the findings and the gaps. We used different WHO and UNICEF frameworks to build up our methodology. Before we deep dive into the findings, just to go through the definition of like mental health promotion, prevention, and literacy, because those concepts can be sometimes like a bit confusing. So when we discuss about mental health promotion programs or intervention activities, we look at actions that improve the positive mental health, the psychological well-being, and that might encompass creating like environments that support the mental health of the children, looking at their parents, positive parenting programs, for example, or like social and emotional learnings. When we refer to prevention programs, we talk about like programs that aim to reduce the incidence, the prevalence, or the recurrence of mental health conditions, disorders, and their disabilities. When we talk about mental health literacy, we talk about like programs that aims to improve, increase knowledge and belief about mental health, mental well-being, and mental health disorders. So 3 separate, but sometimes like overlapping concepts. So at a glance, we identified in Singapore about like 43 intervention activities, and we might have left out some interventions. So if you are aware of your part of the ecosystem and we haven't talked to you, please feel free to approach us. But so far we identified like 43 intervention activities initiatives from 33 organizations who participated in our surveys or our interviews. We ran 37 interviews with more than 50 stakeholders. And we also had some like more informal interview with like policymakers to understand the landscape. Most of these like programs and intervention come from the community nonprofit sector, followed by the public sector and the private sector. One key finding from our mapping is that most of this like program looking like children between like 3 to 11 years old target children between 6 to 11 years old, with really less programs, less activities or intervention, like focusing on the preschool students, like the 3 to 5 years old. It's really like one important findings from the mapping. In terms of the approach that those organization or intervention like adopt, they mostly focus on like mental health promotion, mental health prevention, with a fewer program looking at mental health literacy. It's important to note, as I mentioned earlier, that sometimes those concepts of mental health promotion, prevention, and literacy can be somewhat confusing or difficult to apprehend, and there might be some like overlaps in the response, and so the results might not be completely like accurate. If we deep dive into those like mental health promotion programs that we identified, almost half of them are implemented in the school or the classroom settings, followed by programs implemented in more like a healthcare type of facilities or through like digital like means, followed by programs included in like more like community spaces or like rehabilitation like facilities. And those programs, they embed different type of activities, and we're talking about like mental health promotion, so how to improve like positive mental health and well-being, so like physical activities, building like positive relationships, but also like developing like life skill. I think it's the one of the key activity that have been like identified by this mapping. So developing like life skills, like problem solving, resilience, self-awareness, like mindfulness are those like are the most like prominent activities for those like mental health promotion program. If we look now at the mental health prevention part, most of those like prevention programs, the program that helps reduce the prevalence or the incidence of condition and disorder, they are implemented in like more like community spaces, like either through like family-based programs or like some recreational spaces, sports centers, or rehabilitation facilities, followed by school, and then other like healthcare, like digital type of setting. But the difference in terms of like percentage is not that that important, that's significant. And as we're looking at like mental health prevention program, those programs mostly aim to prevent emotional regulation difficulties in the children, depression and mood disorder, self-harm, trauma, and adverse childhood experiences. And they adopt 3 main preventive strategies in order to reduce the prevalence of those changes. Awareness, so that includes like awareness, like specific awareness campaigns, but also like implementing like community or school policies, like anti-bullying programs, for example. Risk identification, try to train teachers or caregivers to like spot, identify like at-risk children using like screening tools or specific like assessment. But they also like try to implement like early intervention strategies. And in Singapore, that includes like collaborating with healthcare or social services for early intervention and support to the at-risk children. So I hope it's not overwhelming. There's a lot of information. For the mental health literacy program now, what's interesting that 1/3 is mostly implemented in the school classroom setting, the other third in the community spaces, and the other third in the more like other like healthcare type of like facilities. In terms of the components covered in this program, it's about like explaining well-being, what is mental health, what is like well-being, understanding like emotions. They also try to raise awareness and reduce like stigma. And a lot of this like programs, like focus on like the parents and the caregivers, the adults surrounding the children, and the children like developing help-seeking behaviors in the children themselves. People are using different methods: storytelling, role play, structured programs, education material, just like a leaflet, brochure, or having a booth in some exhibition, for example, spaces, or interactive workshops and games and play. And we know that for children, the play type of activity are a very meaningful way to interact with them. So we've seen like, some like key findings of like how those programs and interventions in Singapore are structured and in which type of settings they've been implemented. But we also wanted to understand like how those programs, those interventions, those activities, because they're not all like very structured, like how they've been like implemented, how they've been like designed, and with who. So we use the WHO UNICEF like framework to look at different domains, and one of them is like how participatory were those programs and intervention. And what we noticed that children are occasionally involved in the program design, in the implementation, or the evaluation. And their contribution, is very limited compared to like other stakeholders, like mental health professionals, for example, who play a far more active role in designing or implementing or thinking about the evaluation. And that, could be understood by the fact that we're talking about like younger children and not adolescents. But we also know from the literature that co-designing intervention with the main beneficiary are very important. So it's happy here to be like both promising in Singapore, but also challenging and still relatively new to many organizations in the country. Also, almost all organizations and respondents highlighted the importance of like having like user testing and some like kind of like feedback loop, so that they can improve the relevance of the intervention. We also look at the accessibility, how those programs are accessible to the main beneficiaries. And organization, like most of the organization, like 34, 33, incorporate like different type of accessibility methodologies. So like such as like making sure that the content is appropriate to the age. And, we've been looking at like programs from the age of like 3 to 11. So obviously the development of the children is different at age 3, a bit than at age 11. So we need to make sure that those programs, consider that. They also like adapt some of the program adapted the content for different languages, like Singapore is a multilingual country. Make sure that it's relevant to the different cultures available or present, sorry. And less organization have implemented some accommodation for children with disabilities. So that's one of the gap in terms of accessibility, making sure that we have programs and intervention that are relevant for children with special needs or children with physical and mental health disabilities. A lot of programs try to overcome the financial barrier, providing like the services at little or no cost for the families of the children. So they're trying to like shift, the delivery model from a fee-based to a donation format, or to like embed the programs in everyday setting like schools and clinics to make sure that everybody can benefit from those programs. So it was just, snapshot of all the domains. We also look at human rights. We also look at inclusion and equity. So if you want to have more information about, how we assess and how we screen those programs, like please like have a look at in our report. We also look at how those programs are evaluated and how they are funded. But we don't have much time to share about that today. So yeah, I encourage you to read our report. I will now like finish on the barriers in terms of like program implementation. We ask all the organization and the survey respondent to indicate like and to grade all the barriers in terms of like program implementation. And the biggest barrier to implement programs looking at children at 3 to 11 is the shortage of trained mental health professional, but not only like trained professionals such as psychiatrists or counselors or psychologists, like how other professionals in the social space or in the education system are also trained with some like basic like foundation or basic knowledge around mental health. The other barriers that have been like that surface from this mapping are the limited engagement from caregiver, parents, or family members to support the participation in those programs or to support their own participation. Lack of funding, either from like public, private, or nonprofit sources, also a key barriers, and the limited like public awareness about mental health and what does it mean exactly, because right now we're talking about promotion, prevention, and literacy. But as I said, it can be a bit confusing, and the general population might not be aware of those concepts. So I already mentioned those like barriers, the insufficient like funding resources, it's not different level of prioritization, the change around like stigma. When we talk about like wellbeing or mental health, mostly like parents will still associate this terminology with like severe mental health condition. The logistic changes are quite important because it's very difficult to engage with children who have a very busy agenda in school or after school. And a lot of like challenges and barrier around the parental engagement to support the children in to participate in those programs. So in conclusion, I want to share about this quote from one of our interviewee that say that, those programs really aim to prepare the kids of today in a world where technology and digital consumption are overstimulating the developing brains of this audience. And we want to add that, it's also to prepare the kids of today in a world that experiences significant political, social, and economic changes, and also like conflict. The finding of our mapping have lead us to establish or to list some recommendations, both for funders and implementers, and you can read those recommendations in our report. The first recommendation is to increase the funding base for the younger children, age 3 to 11, to have like more players in the space, or to support the existing like initiative, to adopt a broad and flexible like funding practice, to foster the ecosystem collaboration, knowledge exchange. We really found like very passionate people who have been working in the space. We want to, very keen to share with each other about their work, and want to continue to do that. So we invite funders to support this kind of knowledge exchange, and to support like very comprehensive and multi-domain programs. Working on children mental health requires to have a very systemic approach, not only looking at the mental health of the children themselves, but also at the mental health of the trusted like adults around them. So in families, in school, in the communities. For implementers and practitioners, we invite them to strengthen the evaluation and sustainability approach, especially looking at the evaluation frameworks to make sure that the programs are evidence-based, or show some like positive impact at least, to engage parents and other trusted adults in their programs, to participate in those kind of like exchange platforms, and to embed children's rights as a guiding principle in their programs. So just like some like final remarks before we go to the conversation. So our team, really found that we have a very dynamic and committed ecosystem to support like children mental health in Singapore, with the strong foundation of initiative combining like promotion, prevention, and literacy program. There's a growing interest to look at the younger children mental health, not just the adolescent mental health or the young adult mental health, but current initiatives are limited and constrained by funding, manpower, or awareness of the caregivers. And working on children mental health space involves to leads to work with like multiple stakeholders, not only in the healthcare setting, but also in the social services and the community spaces. As I mentioned, it requires to adopt a systemic approach, and we need more evidence in terms of the impact and the side effects. And we have some discussion later on, especially as there are more like publication on school-based mental health initiatives and the impact in this setting, and also that we lead to like how we can navigate like new trends, like excessive like use of like screen time, increased prevalence of bullying, family dysfunction, the post-pandemic impact. So I hope this was not too like overwhelming, that you learned. You're saying you will have access to the report with the QR code, and thank you very much again for attending this event today. We'll now go to the next stage of our webinar, and I would like to call my panelists and invite them to switch on their cameras. Thank you very much. So I'm very delighted. So like, just please, keep your question for the discussion later. So I'm very delighted to be joined by 3 panelists for today's event. So first, Tawfiq Hamad from Children's Society. So Tawfiq is a dedicated advocate in promoting like children mental health and emotional well-being in Singapore. He has like extensive experience working with youth, children, and communities. He leads the Tinkle Friend helpline. So he will share a bit more about it, which support children aged from 7 to 13 years old through preventive and early intervention. He has been working very closely with educators, community partners to foster empathy, resilience, and safe spaces for children to thrive. So thank you, Tofik, for joining us. We also have Ruth O'Connell. Hi, Ruth. So Ruth is the seasoned mental health and psychosocial support specialist at UNICEF with over 2 decades of experience across humanitarian and development settings in Asia, Africa, and the Middle East. She currently serves as a program specialist at UNICEF East Asia and Pacific Regional Office, where she leads the strategic mental health and psychosocial support initiative with a focus on adolescents. She has contributed in multiple toolkit and publication and programs and provide technical guidance to global organizations. So thank you very much for being part of this panel. And then last but not least, we have Sofia Slumka. She's a psychologist and a Forbes 30 under 30 social entrepreneur. She's currently the research lead at Orygen Global. So she will share more about Orygen, but Orygen is Australia flagship, youth mental health institute with 30 more years of experience in designing intervention for youth mental health care. And the global team helps to translate Orygen findings into diverse settings. And Sofia also co-founded Let's CE, that is the first youth mental health center of Central and Eastern Europe. Thank you, Sofia, for being here with us. So we're going to start with one introductory questions. So maybe Tofik, Ruth, and Sophia after. Could you tell us more about your work at Singapore Student Society, at UNICEF, and at Orygen, and how that's resonates with this mapping on children mental health. So maybe Tofik, if you can introduce yourself and your work. Thanks to start.
Thank you, Anne-Claire. My name is Tofik. I'm from Singapore Children's Society. I lead the children's helpline in Children's Society. It's called Tinkle Friend. So it serves children from 7 years old to 13 years old. I'm going to just share very quickly some slides. I'm told I have 3 to 5 minutes, so I will make sure I don't talk too much. So basically what we do in Children's Society, we have many different services, but I work mainly in a student services center. So I oversee the Tinkle Friend portfolio and also the Bully Free portfolio. So when we had these discussions to and fro for the past few months with Anne-Claire and her team, one of the things that we found out that even when the initial findings came out, there was a lot of similarities in terms of what we have found out also. In terms of we had 2 studies we have done so far. One was the parental perspective study. These are just the initial findings. And one of the things that we found out, there was a mismatch in parent-child narratives where parents tend to underestimate severity of mental health struggles. Children also have unmet emotional needs, and parents may not be able or unable to meet these needs. And as parents, there's some of the things that they understand, that they do understand that children do have their own mental health struggles, but when it comes to their own children, they tend to have their own blind spots with their own children. Other observations, parents tend to take a more very remedial or very reactive approach, and children do tend to mask their behaviors. This is clearly seen in a lot of the calls and the chats that we have in Tinkle Friend, especially when we share with them that we need to tell somebody to keep them safe. One of the things that they always say is, no, I don't want my parents to find out. And most of the time, is this not wanting to burden their parents with their own problems. Probably they have bad experiences. And some of them do find that it's not significant enough to tell anyone at all. And there are also some barriers which also align with the study by the team, by NCLAS team. Just now when she shared about logistical considerations, one of the biggest things that parents always ask is, I don't have time, there's she already has like tuition, she has this, she has swimming classes, she has ballet, and what is the cost like? And what's the schedule? How many sessions do I know that will my child get better? As professionals, it's difficult even for us to put like a number in terms of like how many sessions will the children get better. This is not known. Sometimes it may take 6 months, some may take a few months. And at the same time also, there's this huge component about mental health literacy, where the knowledge and attitudes are where there's unknown factors and known factors, and parents tend to have they may know what is mental health, but gauging the right point of intervention is something that they do struggle with. And they may have limited knowledge in terms of like what are the services available to them. And at the same time also, how do they reach out to these services too? So there was another study done also by the team, or our team at research. This was done like they went through they trawled through Tinkle Friend chats, and they found three things when it comes to children's mental health. There was internal resistance, especially from the children. Absence of needs-based mental health support, especially for younger children, because most of the services for students have been directed towards youth mental health. And they do live and stay in a dismissive environment where sometimes when they tell the parents, maybe it might sound like this, like, don't worry, you'll be okay tomorrow, just go and sleep. And parents may not be able to respond to their child with care and empathy, maybe due to their own competing needs. So one of the things that we are doing at Children's Society, especially at Student Services, is that we have been taking a whole agency approach for mental health training, and that we have dedicated centers to take on mental health tier 2 and tier 3 cases. My colleagues at OMM, they're also here somewhere. They have been the one who have been spearheading this community outreach. They have been doing talks, they have been doing workshops, they have been doing so many things for the schools, for the community partners, for the children, also for the parents. And one of the things that we have also embedded in Tinkle Friend also is that we have embedded a mental health check-in in our Tinkle Friend service too. And when children come into the chat line or the hotline, and they're showing certain signs and symptoms of mental health distress, we then offer them a mental health check-in with a professional trained staff that will attend to them. And the goal of the mental health check-in is to just let them know like what certain points of their lives, certain parts of their life that they're struggling with, and we work with them towards like sharing strategies. And then if there's a need to escalate, or like if there's a need to refer them to other services, other tiered services, we will do accordingly too. So then the real question is, there's still more work to be done, is it? Yeah, so I think I didn't exceed 5 minutes. And yeah, and I'm more than happy to have to answer more questions.
Thank you. Thank you. Terrific. We'll go back to you with more questions. I will now ask Ruth if you could share a bit more about your work at UNICEF, and how UNICEF is playing a role in improving children's mental health and well-being.
Thank you very much, Anne-Claire, and I hope you can hear me. I think it was very interesting to read the report that's come out of Singapore, because I think it really resonates with the approach that we take in UNICEF. So I think obviously the more voices that advocate for this really holistic approach, I think the better. So in UNICEF, we are very engaged and committed to promotion and prevention as well, and we believe that it is really the foundational way to work. We're trying to move away from, I suppose, the traditional model where mental health is treated as mental illness, and it's something that's looked at, I suppose, in a singular way. And we're trying to work to strengthen the mental health and well-being of communities in a number of ways, resulting in a community that's more committed to well-being, but can also is not afraid or ashamed to seek help and support. So in common with your report, I think, and some of the recommendations that we read, we would advocate for programs not to be standalone and not to be done in isolation. So that, for example, in schools, communities, families have an awareness of mental health literacy, which you're calling for very strongly in your report. And I think that resonated with me, because I think once that is in place, then we can address the barriers that you also mentioned in your report, one of which was a lack of awareness and stigma, for example. So we in UNICEF advocate for evidence-based support at community level, which is where we are mandated to work. So we work across the continuum of care, and we use the social ecological model, which means that we work from conception up to adulthood. And it is very interesting what you say about the lack of evidence. We carried out an evidence and data review in 2022, and we noticed that between the ages of 5 and 12, the lack of data is quite astounding. So I was very interested to read in your report why you felt that was, including the difficulty perhaps in consulting with children and the difficulty at the developmental stage. I think maybe practitioners are a little bit more hesitant to approach that age group. So one way, for example, in UNICEF that we feel is an interesting way to work with this is our work in parenting and attachment. So we look very carefully at risk and protective factors at different stages of the life cycle of the child. And as you all know, one of the risk factors for children is a lack of attachment with a secure and responsive caregiver. So, for example, all of these interventions and the interventions that we heard about regarding the helpline in Singapore, for example, we believe that different people would have need for different types of support at different times. So mental health goes from poor mental health to very good mental health, and that we shouldn't be defined by perhaps by stigma and shame for accessing the supports that we all should need using a rights-based approach. So I think that was very interesting as well in your report, that you're really saying that it should be underpinned by this human rights-based approach, which I think is very important. So we work in a number of different ways under this kind of umbrella that I mentioned earlier, where we have standalone programs which are evidence-based and developed for specific age groups. And then we also have a mental health multisectoral approach, where we advocate very strongly for other systems and sectors to contribute. So basically any touch point really that a child would experience in their lives should be psychosocially supportive and enhance the child's well-being and the caregiver. So we work with our mental health framework advocates to work with the child and adolescent caregivers, and in caregivers we include teachers in that, because we feel very strongly that teachers are caregivers of children. And I mean, we just heard earlier from Mr. Ahmed about the challenges that people have in school and the timetables and how busy it is. So I think it's very important to keep caregivers in our mind. And then the third framework element that we have is communities, because we feel that the communities are key, including social workers, including justice, including social welfare. And then finally, we work very hard at the systems level. So all of the work would be underpinned by this strengthening of systems, legislation, and policy. So essentially, that's really the kind of work that we do. We have our standalone programs as well, including programs for caregivers' mental health, school-based programs, which are time-bound and again should be carried out in collaboration with social emotional learning and other programs. We have programs such as EASE, which I know you're very familiar with, for adolescents. And then we have a program similar to EASE for younger children called Bloom, which again is for children that have indicated either behaviorally or symptomatically that they are looking for some kind of support. And we also have a parenting program called Raising Together in this region, which is, I can share more information on these afterwards. And then, of course, which we have our nurturing care framework, which many of you, I'm sure, have contributed to, and through the multi-agency approach. So that's really very briefly the kind of approach that we take in UNICEF. I probably was a bit too quick, but I'm looking forward to learning from other participants as well. And thank you for having me.
Thank you very much. And yeah, we'll ask you many more questions after. Hi, Sophia. So, like, can you introduce yourself, Orygen War, for those who don't know Orygen, and maybe also share about the recent observation, findings, and takeaways globally about youth mental health. And I know Orygen has been driving this work worldwide.
Yes, thank you so much for the kind invite, and what an honor to speak after such esteemed speakers. It was already great to learn from you. My name is Zsófia Slamka, and I'm a psychologist by background, and I have been working with Orygen Global for a number of years by now, so I will try and summarize some of that experience for you. I will also share my screen to do that. Here we come. I wanted to tell you briefly about Orygen first, for those of you who are not yet familiar with the work that we do. Orygen itself is based in Australia, and it is a youth mental health center conducting research and then translating that into policy, as well as providing services to young people in Australia with over 30 years of experience in this field. And then within Orygen, the global team that I am working with has been working in this space since 2018. And we are trying to knowledge translate all the experience that Orygen itself has in youth mental health, capacity build across diverse organizations in different settings, and also try and take a systems perspective when it comes to youth mental health. And so some of the key trends that we have observed in the past years when it comes to improving service access and services for young people is the increase in low intensity service models for youth. That is something that, of course, Orygen itself is very much invested in Australia itself. But we have been partnering with organizations such as Headspace Denmark or learned from Level Mind in Hong Kong to learn about how they do low intensity services. We've also seen AI and how the digital support services have been increasing, and then of course school-based models as well. I wanted to tell you a bit more in depth about what we've seen in school-based mental health interventions. We've done a particular study in collaboration with the World Health Organization's headquarters that is planning a training program for school-based staff on mental health. And so we were looking into, what key strategic directions we see in the literature and in social innovation when it comes to school-based mental health. And so in this review work, what we've seen a few things that do seem to work. We see that when schools offer universal approaches to youth mental health, the best potential in that is early identification. But we see the strongest evidence for mental health promotion with themes such as literacy, increasing mental health literacy, reducing stigma, and improving well-being skills overall. And when a program is targeting a specific group of young people with CBT, mindfulness, or resilience training approaches. We also see quite strong evidence for early intervention. And here, what we see is that the data is typically for short-term effects, but it's much harder to find data on follow-up. What we have also seen is that actually teachers can be just as effective in delivering school-based mental health support as mental health professionals when there's effective training for those teachers. Now, we heard already a lot about gaps, and I guess I will just resonate with that on the one hand, the evidence that we do find comes overwhelmingly from high-income settings. And when it comes to the effect sizes, we see small to moderate effect sizes and quite inconsistent ones, especially when it comes to universal mental health approaches in schools. And then we also see quite heterogeneous outcomes, and a lot of studies just simply lack rigorous methods that for a review would allow us to evaluate how strong that evidence is. And that is to say, I think many times that is because there's not enough funding or there's not enough research trained professionals who could make that happen. And in the data that we do have, we see fairly little focus on implementation approaches and integrating school-based mental health into existing referral pathways. And in terms of what we think is needed next is to move from just very general universal approaches to more targeted and tiered models for youth mental health in schools, to invest more in the training of both teachers and school-based mental health staff, including their supervision, and to strengthen the links to health systems so that we ensure that the programs that we do implement are sustainable on the long run, not just in high-income settings, but across the world. So thank you so much for listening. I'll stop sharing here, and I very much look forward to any questions.
Thank you, Sophia. I have a follow-up question to that. Like, do you see any difference between like primary school and secondary school? Like I know Orygen has been like driving a lot of the work on like adolescent and young adult mental health, and a bit less in the children's space. And I know it's something that you want to focus a bit more, like what you've seen from this review as well on the school base, and obviously, like as we mentioned in how like as we highlighted in how mapping findings, schools are one of the key settings to implement those type of interventions because of the enrollment of the children in school, right? So there's a lot of interest to implement school-based programs.
Yeah, so that's a great question. So when it comes to when it comes to the evidence that we did find, when you separate it into different age groups, the evidence, which I said was already, let's say, scarce, then you have even less studies that would focus on just primary school, just secondary school, but you would find some. I think there's two things where the evidence is much stronger. One, when you look into, if you move away from the gold standard evidence of randomized controlled trials, and if you look into social innovation and how that socially innovative projects have been implemented in primary school or secondary school, that's where you have much stronger evidence. And the other thing that we found to be very exciting is that actually, not in mental health specifically, but when it comes to health literacy and mental health literacy offline in schools, there has been some research looking into what is developmentally appropriate. It's an emerging field, but there are some excellent scholars out there thinking about ways in which we can address developmental needs of different age groups, starting from the youngest ones up to basically young adulthood. And that was very exciting to see, because it means that that gap is acknowledged and there are people who are actively thinking about how best to address those specific groups.
Thanks. And the it's like review for WHO, is it like available like online, or will it be available? So I'm sure that there are many people in the audience who might like want to access it.
Basically, we have submitted it for publication as a manuscript, but let me look into it, because I know that the WHO also wanted to make it available publicly.
Thanks. Thank you. Thanks. Maybe then in the meantime we'll move back to Tawfiq. Tawfiq, can you share a bit more about those like challenges that you see on the ground regarding this like young age like population, and share a bit more about the what Tinker Friend the helpline is. I think there's also some question in the audience about that. Yeah.
I think I read the question that I think that they were asking. I think they were asking like what's the profile of the children who reach out to Tinkle Friend, and like what's the ages. So on paper we do on paper is 7 to 13, but we don't have a closed door policy. So even if you are 14, 15, or 16, we will still engage you. But at the same time also, if it is really hard to say, because there are seasons during the Tinkle Friend, like the more calls or lesser calls. So during the holidays, sometimes you will get lesser calls. but during the exam periods or before the exam periods, during and about a week or two when they get back their results, the calls tend to be higher. Then in terms, however, I also say during the June holidays or the December holidays, low calls doesn't mean less intense. It could and most of the time the higher calls we get is usually in the months of January. It is actually, to be very honest, it's actually very hard to put a number like in terms of like how many calls are there in terms of mental health chats or calls. But generally, we are looking at about 3 to 4 a day. We are children coming in with mental health issues, and and we have also seen an increase in self-harm and suicide risk, especially in the calls in the past 3 years.
And what's the the age range? I know that you've seen an increase of like phone call from young children, but maybe can you share and what's like on the ground the key like issues that those children call you like face and why they call you?
Most of the times is usually be like peer relationships, family issues, and also school, and when even when we do our mental health check-ins, there are certain portions of the test, or not of the test, of the questionnaire that we ask, questions about their peer relationships, their school, and also their emotions at that point of time. Usually the ones I would say 10, 11, 12, and 13. Yeah, around that age. Yeah, 10, 11, 12, 13.
Thank you, Dr. Right. To talk with Ruth about like UNICEF role and what you've been doing in Asia. Maybe can you share a bit more about those programs that you mentioned, especially for the younger children and how those have been like implemented maybe in this region, like and how you support like countries who are trying to implement those programs.
Yes, thank you for the question. So, as I said, the programs that we have developed on top of the approaches are evidence-based. So we go through a very rigorous procedure to develop the programs, and more often than not, they're co-designed. Obviously, with the littler children, that's not always possible. That's not the case. But for these programs that we have, we are advocating that they can be carried out by non-specialists, but there is a very strict so by non-specialist, I mean, it doesn't have to be a psychiatrist, but it could be a social worker, it could be a community worker, it could be a midwife, it could be a teacher, depending on the program that we're implementing. And these programs usually are time-bound, and so there would be certain criteria to enter, and we would have a very strict monitoring and supervisory element to these programs. So they would be supervised by professionals, and there is a strong element as well in them of self-care. So in this region, what we're finding is that they're being most typically taken up by schools with early adolescence. So that's what we've been seeing mostly. So the programs are available. Obviously, the resource heavy, I suppose, part of the work is the training that's involved. So we have training of trainers packages to go and support these tools. So mostly what we find is that they're being carried out in school settings. And the ones that are most popular are the ones that have an element of caregiver engagement with them as well. Pardon me, excuse me. So we would, for example, in the Helping Adolescents Thrive program, we have one for early adolescents and we have for late adolescents. And we would advocate very strongly that unless the caregivers can participate at certain points in the program, that it really shouldn't go ahead, because we're really looking for a family-based approach. And then with Bloom, which is for our younger children, it's really in the very early stages. So we're only just finishing the trials of it at the moment. But again, there is a lot of engagement from caregivers as well. And it's based a lot on, I suppose, strengthening resilience through creative approaches, but again, using evidence-based and evidence-generated mental health responses.
And usually when like an organization or I don't know, a country government like wants to like implement those intervention in their setting in the country, like how do they access those programs? How can they know about them? Yeah.
Yes, so as you know, UNICEF works through partners. So what would typically happen is we would have implementing partners in the countries where we work. So they would be trained to facilitate these programs. If not, then we would work with the government. So for example, I was just recently in Vietnam and I was recently in China training teachers directly on these tools. And then we usually would use a cascade model. And how governments become aware of it is through this really systemic strengthening and advocacy for legislation and policy to come. So then governments can decide how they would like to strengthen mental health in schools, for example, or in communities, or in primary health care, or in perinatal mental health, or whatever way really is most appropriate to them. But all the work is really underpinned by that.
And a bit to Sophia, like, and to create a link with that, like, so Orygen has been also a strong advocate for like youth mental health, and there was some like recent publication about like youth mental health advocacy, and but the focus has been a bit more on like adolescent and young adults. Like, do you foresee to step into the younger like age like space?
Yeah, that's a good question. I think the reason why there has been such a focus on the late adolescent, young adult age groups is because of a gap in services that we would observe in many countries. Acknowledging the fact that, of course, across all ages, children and young people need the mental health support. But in the meantime, what we see is that in many countries, public health services eligibility would go up to roughly 18 years of age. But then around that time, there's a gap that where the young people fall out of services. And that is why there has been a focus on that age group up to young adulthood. Now, when it comes to pieces of work, when it comes to the research that we do on youth mental health, whether it's about digital mental health, for example, Orygen Digital has developed the MOST services, which look at the provision of digital mental health support to young people. There we would also look at the younger age groups. And with low intensity services, again, as to where exactly the lower end lies with a young person accessing the service, that would depend on the actual implementer. So while yes, and let's say in Australia itself, when it comes to the Headspace model, that focuses on 12 to 25-year-olds. But then at Global, when we help other innovators or other public health systems think about what a service package would look like for them, then we would help translate the knowledge that we have onto what they think would best fit their system.
I'll go through, like, we have quite a few questions from the audience, and there are questions around like how to like involve like children in being like ambassadors of like mental health like advocacy, and I think that goes along as how we involve them as like to co-design, especially the younger children, right? How we can invite them to like co-design this program, because we know that the co-designing part is quite key, and we've been talking a lot about that in the mental health like space, like nothing about us without her. So how do we like apply that to younger children? I don't know, like how UNICEF involve like children in this space.
Yeah, that's a really good question. And I think so we have different cohorts that we would engage with. And I think one of the difficulties that can be faced, or that we faced, I know certainly years ago, was that we would ask the same children all the time. We would ask the same cohort of children all the time who were, particularly educated, or who had parents that were engaged, or something like that. So now what we're trying to do is to really broaden the reach of the children that we engage with, and we have ways of engaging with them using creative and participatory approaches. We also have youth advocates for mental health in different countries in the region who are responsible themselves for facilitating workshops, for carrying out campaigns to really find out what the needs of young people are. And then if we develop a resource, or we want to pilot something, or we want to look at something, then we would engage with the young people themselves throughout the process, pardon me, from the very beginning. I think it's very important to start from the start. And we also have school-based projects for peer support for mental health called I Support My Friends, which is about broadening awareness, mental health literacy, and supporting each other and referring to trusted adults. So there's all these little steps that we would carry out to ensure that children's voices are captured as much as possible.
And kind of a related question, I think, because our report like introduced the concept of like children's rights, because we used the WHO UNICEF like a framework to assess or go through the different like intervention. I think somehow this can be a new it's not a new concept, but thinking about like children rights and how those like organization can like amplify or can base the action on the children rights is quite new. What would be your recommendation, to advocate for children rights, or to like train like those like organizations in the space about like children rights?
Is that a question for me?
Yeah, sorry.
Oh, yeah.
Yeah.
Thank you. So for me, I think that we should integrate rights awareness and rights training at the curricula of whatever section of the community is being trained. So for example, in teacher training, and there should also be modules in schools. I don't think necessarily that adding, I think particularly in schools, teachers are really busy, and we're always asking teachers to do all the things. So I think it should be as part of any standard curriculum or any on-the-job training or university. I mean, in an ideal world, that we should be learning about human rights and children's rights as part of that. So I don't think we should consider it to be a separate thing. I think positively for me, when I read the report, everything that is recommended there is embedded in children's rights. So I do think a lot of institutions are meeting the children's rights and are upholding the rights of children, but it's about framing it, and it's about looking at what we already do, rather than trying to inject this new piece of or project or separate thing when people are already so overwhelmed. But I think we should start doing it earlier, and we should encourage children to be responsible as well, to learn about their own rights so they can advocate also at all levels, really.
Thanks. We have a question about like parents. I've been talking about children and parents, and parents are one of the hardest like group to reach, and I think a lot of the interviewees and survey respondents like share that with us, often for fear of their children being labeled as having issues, or afraid to be like labeled as a failed parent. Maybe like could the panel like can share about their experience on how to best like engage with like parents? I don't know, like Tawfiq, do you want to share your experience at Children's Society? Yeah,
I think this is parents are usually is really the hardest, because due to competing demands, when they have little work, they have too much work, and then the only time when they have is on the weekends, and then they only have a certain amount of time. So one of the things that the society has done, Children's Society has done, is that just recently, I think a few months back, I think in May, we did have a parent and child activity, and it may sound like a very novel activity, but it was to build a terrarium, and the design of the activities needs to be not so much novel, but interesting, exciting, and then there's a takeaway for both parent and child. So one of the things that we did was we did a parent-child bonding activity, and then there was portions of mental health awareness and knowledge being shared. Also, this was done by my colleagues. She's also here today. And when and it's also in line in terms of like the outcomes and recommendations that your team has come up with, and Claire, where programs that have both parent and child activity together, engagement together, has higher take-up rate. So I think that's that's really evidence-based we're looking at. And I think most designs, when we talk about parents, it needs to be engaging, it needs to be exciting for both parent and child at the same time. And it needs to be planned. It cannot be too short, it cannot be too long. And I think this takes a little bit of time and experience to like figure out like what works best.
Thanks for sharing about your. I think what we've heard also from some certain groups that, you know, like even if it's just a school-based like intervention, like with a program dedicated to the children, making sure that, you know, the parents receive a newsletter or some kind of information, or they can like participate in a like a, you know, short session about mental health. So like, yeah, trying to find like ways, but I think certainly this question on like involving parents was one of the most like challenging question that we identified through the mapping.
Can I actually come in with a thought
yeah.
on that?
Yeah, sure.
Yeah, sorry, just a brief one. That actually I resonate very much with what was said earlier, and wanted to share what came up in some of the work we have done. I mentioned low intensity approaches, so a big part of what we are hoping to do in different contexts is to help organizations think about how they do their own version or their own adaptation of a low intensity service model for young people. And so the example I bring is from Headspace Denmark, where they run a mostly volunteering-based low-intensity, a network of youth mental health hubs, taking a low-intensity approach. And so they were telling us that basically the question of having families involved was so apparent, was so important, that they actually recently started their own, like a family-specific program, because the low-intensity service would typically focus on the young person. It's the young person coming into the service. It's the young person who engages with a professional or a volunteer. And so the family-specific program is indeed there to involve the parents and to help work on family dynamics as well. So just wanted to share that.
Thank you. Thank you. Maybe we'll stay with you, Sophia, because we have a question on the, you know, outcomes and what kind of like, you know, outcomes, meaningful outcomes we should like assess when we evaluate those kind of like children or like youth mental health intervention. Maybe can you share a bit more about like what kind of like outcomes you identified during your review?
Yeah. Okay, so this is of course a question that we can talk about for hours. I think, and this has become so important that, so let's say from Orygen Global's perspective, what we see is that when it comes to a low intensity service model, then you would have outcomes that relate to the service itself, how well it works, how efficient it is, what improvements in mental health and in quality of life a service would allow for, to what extent and how both young people and professionals and even the family, how they develop their rapport or the relationship between each other. But then when it comes to, for example, supporting social innovators developing their own mental health projects, then the way they define their own outcomes could be very different. And then likewise, from a funder's perspective, when a funder decides to invest into a new program or to something that has already been proven to work in certain settings, then they might define their own outcomes. So I think recently in the field, this question of setting outcomes that can be standardized, that can be shared across settings, has become very important. So I would love to let's say, point to an initiative that seems to be trying to that is trying to solve this question, and that's the common mental health outcomes initiative, where the idea is to have a number of outcome measures measuring mental health related outcomes that we could all be using across very different settings. Those right now focus on questions like anxiety and depression. So I think there's also a recognition of the fact that well-being outcomes are not yet covered in this initiative. And I think the field is also moving that way. But that is to say that I think if we are able to find outcomes and measures that are used across different settings, then the big advantage is that then I can go or I can take a look at this study from Singapore or this study from Malaysia, and I can compare across the results and not just have standalone studies from different places. Yes, I will stop here because otherwise I keep talking.
Thanks. Thank you very much. What we also noticed while doing this mapping that can be a bit challenging to involve the children themselves, in like responding to some like surveys or contributing in like standardized like questionnaires. And there have been some like initiative in few groups to like develop like smiley or emoji type of like surveys, so that to make sure that we don't lose the voice of the children themselves when we assess the outcomes of this kind of intervention. Because if we look at like evaluating intervention for younger children, it's obviously like very difficult in terms because of the literacy and development phase to have them like respond to a survey questionnaire, right? But I'm curious. I don't know if UNICEF has some like good practices, or if Sophia, you saw some good practice in how to involve not just the parents or the caregivers of the children, but to involve to make sure that the children themselves, contribute in like evaluating those programs or give their voice at least. What's you're muted? Yeah.
Yeah, I mean, I'm really looking forward to hearing Sophia's answer to this question as well. I think it's something.
Yeah.
I think it's a really important question, and we're always grappling with this. So we have guidelines that we're constantly developing and looking at, and I think that the things that we have learned when it comes to engaging with children and engaging with young people is that the approaches that we use really need to be contextualized. So that we're not, for example, using something that might have worked in one country and one income level country, for example, and then going to another, or assuming that children like to be consulted in the same way. And I think as well, the other thing that we've learned, as well as the practical tools that we have developed to engage with children, including in monitoring and evaluation and different stages, there's different ways that caregivers like to be approached, and there's different ways that families like to be consulted. So I think that is one key outcome for us, as well as the participatory and creative approaches that I think are quite universal, but we have to be very careful about the contextualization, the adaptation process that we use when we are consulting with children, particularly on issues related to mental health. And I think the other thing that we also do is that we don't consult unless we have a very clear support and follow-up system in place when we're consulting children about issues around mental health and well-being, which again is why we wouldn't do it in a standalone capacity. But technically, to work using creative approaches linked to our M&E colleagues to try and really get this very useful evidence base from these children that can benefit so much from the work.
Thanks.
Thank you.
I can add to that maybe that I think the work that is ahead of us is also to adjust our own standards as adults on what are the right ways of measurement. I think mental health and psychological sciences are heavily influenced by the positivist paradigm towards measurement. So we are trying to standardize, we are trying to measure, we try to quantify things. And I'm by no means saying that there's a problem with that. But when it comes to gathering outcomes and results from certain groups of people, and that would include the youngest ones, the youngest children, actually qualitative results or qualitative methods are so great. And so we have seen some of those studies that use art, that use storytelling, that use creativity to do that. And in fact, when we look at a very, very, well, somewhat different field, when we look into how children are being involved in court cases, that's exactly the way in which that is being done. So those methods are there, they exist, and they work well. I think it's more a matter of acknowledging in our fields as well that those are indeed methods and types of results that we can integrate next to, let's say, the quantitative data. So I think that's our work to do, as, let's say, researchers, funders, and people who can actually make decisions about it.
Thank you very much. We have a question about how landscape, and did we involve like teachers? Did we interview teachers in the landscape? So unfortunately, we're not able to directly like interview teachers from like local primary school, but we did talk to a few like international school based in Singapore, and you know, even like within the organizations, the local organizations working on like mental health. I think that there's a lot of discussion around like how teachers like play a key role, but how we should like also care for the mental health of the teachers. You know, like we do understand that's a very important topic. Teachers, like, you know, medical professionals are one of the profession that is the more at risk of like burnout. So we like when we think about having a systemic like approach to improve the mental health of the children, we also need to look at the mental health of the teachers. And there was another question about like how we can like expand you know, the workforce, because we saw in how like in how mapping that like the shortage of like mental health professional was one of the key barriers. But as Ruth mentioned, and has the scientific literature like, you know, shows that we don't necessarily like need like psychiatrists and psychologists to deliver this type of like program, and we can like train like lay workers and community workers and social workers, you know, to deliver this program in the community, in schools, and that would like then include like teacher themselves. And there are some like literature showing that when you also like train teachers in delivering this type of like program, that's also like support them in like managing the classroom, that help them then to also like improve their own well-being. So there's a lot of like benefit and a lot of things to look at. But for example, the EASE program, the Early Adolescent Skills for Emotion program that was mentioned earlier, developed by UNICEF and WHO, is a group-based intervention for children, for adolescents aged 10 to 15 years old, who have internalized symptoms of depression and anxiety. And this program is delivered by like community workers. It's like 7 sessions for the children, 3 sessions for the caregivers. So it's, you know, includes the caregiver, the adults, CBT based, but, you know, with training, the lay workers, who could be a teacher, who could be someone in the community, who could be a social worker, to then run and facilitate the group with supervision from a mental health like specialist. So there, I think outside in the literature, you know, many programs looking at expanding the workforce, because we, you know, understand that globally there is a shortage of mental health professionals. So we'll be happy to share about that, and you know, there's also like programs looking at like how peer supporters and people with lived experience can themselves you know, deliver this type of intervention. Let me go quickly through the other questions, as we only have like 5 minutes left. So this question may be more for Tofik about, you know, so there's a spectrum of mental health needs and well-being across like developmental stage of children, and frequently in community-based settings with early intervention services, programs like touch points. We do have children with more like complex mental health needs and presentation, like trauma, for example. So how can we work, you know, collaboratively in the Singapore context among like multiple agencies, caregivers, without losing the voice of the children and ensuring like continuity of care. Any experience or any sharing about that?
I can share with you from the Think Friend perspective.
Yeah, thanks.
I think when we talk about community-based settings, we always ensure that we keep good relationships with other community partners. Say even for example, like the police or even NAVH or even REACH or even KKH. So one of the things that we really need to acknowledge is that even like the work that we do at Think Friend, we don't work in a silo. Where there are times where we need to refer, we need to consult. We always reach out to other agencies, or even like within Children's Society alone, we will also like consult in terms of like the department that does mental health within our agency. So it is really like for us to be responsible to consult if there's some things that we don't know. Because I'll be very honest with you that when there are tier 3 cases, it is sometimes beyond us, and we definitely need to consult like the other professionals that are well versed in this, are managing and are handling this type of cases.
Thanks. Thank you very much. Maybe I take another question before we end. There's a question about like using like there are two interesting questions. One question about like using AI for program delivery and like scaling up like programs. I don't know if anyone has like experience with that, or what's your take up to like how we can use AI to like deliver this type of like mental health promotion, prevention, or literacy program. And there's another question about like like co-designing like programs with children and children like so there's this quote from one of our participants. How do you tell us to care about our mental health, but at home, at school, we don't always feel cared for or safe to talk about how we are feeling. Adults tell us to practice resilience and mindfulness, but sometimes it feels like no one is really listening or believing us. So how we deal with that like contradiction? How we ensure that we provide services for the children themselves, but we also work on the environment to make sure that children like feel safe. So how we create systems and practices to make sure that children can truly experience those approaches. Anyone wants to either respond to the AI question or this one?
I can go
1
quickly
minute
on
left.
the AI one.
Yeah, thanks.
I think the AI one, briefly, it's such a contradicting topic. I know that many people, I think there's a lot of emotions that we all feel about it in both positive and negative ways. In terms of optimizing our own workload, it seems to be effective, while that's not a mental health specific outcome. And then I think what's exciting to see is that many countries are investing into specific evaluation schemes for AI and digital tech related solutions. So I think that's the right way. The innovation keeps going, and then we see what actually works and we promote that.
Maybe in the system approach, I think from the literature and from the advocacy work on the mental health space, we do understand that there is so many determinants to the mental health of not only the children, right, but also the adults. And it's not just about like providing services to those in need, but it's also how we act on those like determinants, and that means there's like the parenting, the education system, the housing, climate change, and many other determinants. It's challenging topic because that involves like working with like many different type of like government representatives, different like stakeholders, but But for sure, there's a contradiction that we need to tackle if we want, to move forward and to improve the mental health of the population, not just like providing services, but improving the environments to make sure that people are in a safe environment. Unfortunately, it's time for us to end this webinar. There's still a few questions. Feel free to reach out to us if you want to know more about the examples of like programs that we identified in our mapping. So there's a bit of question around that, or if you have any other questions around the children mental health space. We'd love to have you join our other webinars and events. So like do register for our MHN newsletter, and wish you all a great day, a great afternoon, a great morning, and thank you again for all our panelists to have joined this event. Thank you all. Bye.